do something a little bit different. We wanted to talk about a lot of the issues around transitions and team transitions that frequently come up, kind of review them and have a discussion. And some of this is a preface for later in the week. Sneha's we're gonna have an actual kind of admission exercise to work through, kind of working through in real time how to triage admissions, helping interns prepare for our 2-year and our 3s think about how to approach when you're getting a lot of complex, sick admissions. So first thing we wanted to talk about today is admissions. Again, talking about how you triage when you get a lot of admissions, what orders to put in when, and when to decide to evaluate them, and making sure you're writing your notes and sign out in a timely way. So just as a heads up, we know that it's the case that on most admitting shifts, you get multiple admissions at once, or at least hear about multiple admissions before you're able to see the first one. Since I know we have a couple of all-star R3s hiding in the back eating, with some timely mouthfuls over there, Dr. Caruso, how do you approach when I think probably the most classic version of this is walking into the Denver Health swing shift, but also swing shift here, where you are just in line to get the next 6 admissions. When you get called 3 admissions at once, each one seems sicker than the last, what do you do after you're done panicking?
What do I typically do? Well, anybody that's like a missing transfer, I tend to just kind of ignore for several hours. They have orders, and they're probably okay if they're coming out of the NICU. And then typically I'll just look at everybody's chart, which I typically do when I accept them from the ED, because I do everything I can to avoid accepting all the patients from the ED. And then anybody who has like any unstable vital sign is like the person I'll see first. But I typically still put orders in for everybody. But typically look at vitals for whatever number of patients those are, and then put in basic orders so they get this, and they're sort of yelling when they get to the floor. And then I go see them all.
Excellent. So I know it can be hard to hear with the microphones all over the room, but so Dr. Caruso kind of walked us through what he does, saying he looks briefly at all the charts, especially vital signs. Anyone who's transferring from the NICU, they've already been seen and staffed for the day, and as long as their vitals look okay, it's reasonable to put them off. They probably don't need to be seen quickly. Everyone else kind of mentally triage based on vital signs, initial labs, and what you see in the chart, and the most unstable vital signs should be seen first. I know it seems obvious, but I think when you get a lot of work, it's hard to mentally prepare that. And the other thing is putting those basic admission orders in first thing, because it's likely that at least some of these patients are going to get to the floor before you see them, and it saves calls, secure chats from the nurse asking for the basics. So other tips and tricks we have, everyone has some kind of template for an admission, usually a sheet or a half sheet of paper. I typically find it helpful to have however many admissions you're open for, that many templates ready to go. It's nice because then you don't have to waste time writing a new one, and then also when you get to the end, you kind of automatically know that you've done your maximum number of admissions, and it's time for someone else to start taking those. As Chris was saying, you want to review a very brief chart review immediately to decide, is this an appropriate level of care? And if this is an appropriate level of care, how quickly do they need to be seen? And then for placing those basic admission orders, I think we say that a lot, what do we mean? That's what team is the patient going to, who's the attending, the vital signs, frequency, and parameters, and then the code status. That's because you have to place it in order to place admission orders, and it's okay to change this later, but err on the side of full code unless there's other obvious documentation. And then BPE prophylaxis, again, you can change this later, but in order to place admission orders, you have to choose something. And then after taking that brief look at the chart and starting to develop what you think might be going on with this patient, think about like, oh, they look pretty septic. I didn't see blood cultures and antibiotics. So place those other few obvious orders. Remember, you can go back and place as many orders as you want, but just get some very basic things in line. The other things that this is helpful for is going through the admission orders, you have to go at least skim by the home meds. Skim that list and take a look at any important medications they might be on. And as you're putting these first set of orders in and skimming the chart, start to think about the information you're going to need from the patient. Is it going to be a really long interview because they've never been here before and they're not on any medications but they're very sick? Or is it a pretty straightforward patient coming in with what looks like an asthma exacerbation who comes in with something similar all the time? And then with that it's helpful to develop a system you use consistently, just like for, your note, sign out labs during the day. Make sure you have a system to ensure that you add them to sign out, have a good set of orders going, and finish the note, and ideally review home medications before you leave. And I'll let Sneha take here.
Yeah, so a word about sort of how to go about talking with patients and actions during these encounters, especially when you're on admitting, because you'll be getting 8 to 10 admissions. And so on these types of shifts, it's okay to work on the computer while you're interviewing the patient, because if you keep track of things just in your mind, you'll confuse them. So ask for permission, say, I want to make sure I have the most accurate information. Is it okay if I chart? At the VA, it's not so easy to badge in, badge out of computers, but you can have a workstation on wheels for yourself that you take around the hospital as you're interviewing patients. And then what I normally do is I start a note, and then as I'm chatting with the patient, when differentials come to my mind, new problems arise, I start jotting them down in the note right away. And so you have this template to go off of. And then as you become an advanced admitter, an R3, you're at DH by yourself, you can also start to add orders and pen them, and then come back later when you're thinking about the patient more deeply. And then I just wanted to show an example of what my basic admission sheet looks like. This isn't what I use to interview the patient with. This is the sheet I use when I'm talking to the ED for their sign out, and when I'm just quickly pre-charting before I go and see them. And I'll make, like Amelia said, up to 8 to 10 admits. And then if I know I'm going to be on nights for a week, then I make these sheets look really pretty. I photocopy them on the first day and make 60 copies. That's probably too many, but make enough copies for yourself so that you can just use them throughout the week, so that you're not spending 20, 30 minutes making these at the start of each of your shifts. And then for morning sign out, when you're the person signing out these admissions, you have to keep track of signing out every admission, because if you don't sign one out, the team misses that they're on their list and the patient doesn't get seen till noon. So make sure you're signing out every admission. Don't have to be a big formal presentation as if you would to an attending. Just give the key parts of the story, the top 3 problems, and then any to-dos that the day team needs to start thinking about right away. And then if you're receiving this sign out, make sure you're actively listening, but trust but verify the story, and make sure you interview the patients yourself to get the key pieces of information right out of the mouth of the patient. Nighttime is busy, you have many admissions, and somebody might have miswritten something in their H&P. You don't have enough time to really flesh out all the story. And so do that yourself in the morning. And then when you're presenting this patient to the rest of your team during rounds, don't read off of the admission H&P. Instead, tell the information that you've gathered, and you can use this H&P for assistance and extra information. And then, so Amelia mentioned this earlier, but for all of the interns that are on or will be watching later, we wanted to give you an opportunity to try and work through managing multiple admissions at once. Amelia, sure, she's done this. I've done this. Dr. Rains is on here. He's done this. We've had 3 or 4 admissions called at once, and you have to understand and learn how to juggle these and triage who you'll go see first, who needs orders first, etc. So if you want to practice this, please reach out and we'll get you on a conference with us.
Awesome. Any other, I know this is kind of like a brief overview, some of it's basic, some of it's more high level. Any questions, thoughts, concerns?
Can I
Jason?
say something real quick?
Yeah, please.
'Cause I think this is an important process. I'm Jason, I'm through here, so when there's a outside hospital transfer, you should, once you find out that they've arrived, you should proactively ask for a set of vital signs. A lot of times the nurses will just get them, but they won't always get them, and that's really important. And then even if you're really, really busy, you should just go at least eyeball them within about 30 minutes. Because the difference between an outside hospital transfer and an ED, they've gone through the emergency room, they've been evaluated, they have vitals, they have labs, they have all that stuff. Usually with direct admissions as well, but outside hospital transfers can be a lot sicker than advertised. I've had 2 people on swim shifts here that were in shock when I went to the bedside, like 60 over undetectable blood pressures, and you go to the so vital signs right away, eyeball them within 30 minutes.
Thank you. And just make sure everyone's heard it. Dr. John was sharing that outside hospital transfers at all hospitals, actually just because of a variety of system reasons, you don't hear about them until they arrive on the floor and have a bed. And so when that happens, really prioritize seeing them first because they may not have been seen by a provider, and prioritize putting their orders in, at least their basic orders in, before other folks, because you are the only provider responsible for them or who has seen them recently. Oftentimes we might get called about an outside hospital transfer at 8 a.m. and they may not get here till midnight, depending on weather and how far away they're coming from. Okay. So the next thing we just wanted to briefly touch on are procedures. Depending on your service, you're going to do variable amounts and numbers of procedures, but just a quick do's and don'ts for procedures. So obviously, always remember to get consent. Everywhere we are, we need to do that. And remember that blood transfusions need to be reconsented every admission. Make sure you refresh yourself on the steps of the procedure, especially if it's been a while since you did one. This QR code takes you to the New England Journal of Medicine website that has many procedures that we don't do, but videos of nearly every procedure you can imagine. JAMA also has a pretty good video series if you just want to refresh yourself before doing something you haven't done for a while. Next, and it's very important, please do get supervision. Not necessarily because you are not skilled at the at whatever procedure you're about to perform, but it's really important for all the hospitals. They actually are not able to bill for procedures if an attending is not in the room when it happens. And that's a lot of lost revenue for hospitals. Absolutely, like Denver Health NICU overnight, we don't call attendings in to do those procedures. But if there's an attending present and available to stick their head in, please let them know. In addition, if it's a sicker patient, something you have any questions about, it's good to have someone there who can back you up, talk you through it if it starts to get complicated. Also, always remember to use the ultrasound. And Sneha, do you mind jumping in and reminding us where those ultrasounds are located? I think you might be muted.
Sorry. The ultrasounds in the ICU should be located in the ICU, so just ask the nurses and they can help you find those. At the VA, the hospitalist team room on K2 has about 2 to 3 portable ultrasounds, which are really great, and you just carry them to the patient's room. They're super fast. At the university, they've changed locations from the 11th floor storage area to now the 9th floor hospitalist workroom. And you should just page the proceduralist and let them know that you're borrowing the ultrasound. And Amelia, Denver Health, I don't remember, can you remind us?
Yeah, no worries. Yeah, so Denver Health, there's a couple in the ICU, and then there's also one on the 8th floor at the main nurses station. If it's not there, you can ask the clerk or the charge nurse, and they're usually able to help you find it. And then overall for every procedure, know your limits and ask for help. There's no shame in asking for help just because, or just asking for someone to watch you because you haven't done something for a while. And then along with all of that, don't ever rush, do a procedure you're uncomfortable with, or defer to the day team. I think there's a fine line here, absolutely. If it's 4 a.m. and you're at the end of a 24, you're really tired and you don't think it's safe to do a procedure, that's one thing. But if a patient is on pressors and is going to clearly need pressors moving forward, it's always easier to do something now, if at all possible, than in an hour or two. I think everyone during the day gets really busy really quickly. And so whatever you're able to do to help your colleagues out, please do. Yeah.
Can we add to this is get labs on people, specifically an INR and platelets? Like,
Yeah.
Almost none of the procedures we do are emergent, meaning you have 45 minutes to know that their INR isn't 9 before you stick something in their neck or in their wrist, for that matter.
Yeah, absolutely. So with that, like, probably under the refresh yourself, always be aware of the basics of the patient. And I would argue really, yeah, none of the procedures we do should be so emergent that we can't wait to find out that it's safe based on their labs. Okay. So speaking of Emergence, we also wanted to touch quickly on the emergent situations that we do find ourselves in, starting with rapid responses. I think these are probably my least favorite things because they can be very high pressure and very challenging. You're essentially evaluating a patient that's getting worse, and people probably aren't sure why, because if they knew why, they would have done something about it to change that already. So with that, I think it's really important almost to approach this as if it's with a completely clean slate, even if it's a patient you've been following. Look at their vitals, hear what's going on now and what brought them in. Again, review the labs and the imaging from admission. Think about any getting repeats now, or look at the most recent ones as well, and then try and figure out the timeline of decompensation. I think the challenging thing here is you're going to come in a room, someone's sick, there's probably the rapid response nurse, the patient's nurse, members of the primary team, maybe a pharmacist. A lot of people are talking, a lot of people want to give you information that's helpful. Try and do your best to gather kind of the objective information, but not necessarily be too anchored by any one person's idea. And try and think about it. If I was walking in, I knew nothing about this patient before right now, what would I think is going on? I think the best example I can give of this is a patient that I had came to us in the cardiac ICU as an intern. She'd come in with heart failure and started to have lower and lower blood pressures, but she was tachycardic. For all the world, we thought she looked septic, but she'd come in with heart failure, and everyone was like, well, I think her heart failure is just getting worse. She, in fact, was septic from C. diff and had a perforation from the C. diff. So I think it's really, really easy to remember, or really easy to forget that people can develop new problems in the hospital, and you need to kind of continually adjust your approach. On the other hand,
Amelia, can I jump in there for a second?
Yeah.
For rapid responses, in some ways, for me, rapid responses are harder than codes. And if you end up at a rapid in a weird area of the hospital, like once I was on an overnight shift at the VA and a rapid was called on a patient that was there for like sleep study overnight, and the patient started seizing versus had a stroke, who knows? They fell out of bed and I had to go over there. If you're in a hallway, if you're in an outpatient clinic and this happens, just remember that the priority for those patients is to get to the ED as quickly as possible. So make sure that somebody is arranging for a stretcher so that you can get the patient to the ED for a better evaluation, because it'll be very difficult to do anything in that odd area the patient is in. Of course, they're already in a hospital bed. That's easy. Consider transferring them to ICU versus taking care of them where they are.
Awesome, thanks. And I completely agree. I think rapid responses are probably the most challenging situation we find ourselves in. I think codes are also feel very stressful. With that, always remember, if you're going to be holding the code pager during your time, review the roles that you want everyone to have before the code pager goes off. On the first day of the rotation, say, senior, I'll be leading the code. Intern, I want you on pulses. Med student, it's helpful if you start looking at the chart and yelling out recent labs, or whatever you think is most helpful. When you walk into the room, make sure you introduce yourself as the code leader. I'm Dr. Caruso, R3 with the MICU, I'll be leading this code. And then the next thing that you do, and the thing that you should be continually ensuring while you're in the room of a code, is high quality CPR. Just as Sneha was saying with a rapid response, sometimes that means moving the patient. There was a code here that I walked into where the patient had been found face down in the bathroom. And so saying, no, we need to flip them over, put them on a stretcher, and get them kind of in the middle of the room so everyone can access them. Because being in tight quarters in a bathroom isn't going to be helpful for anyone. Then as soon as you have high quality CPR going and a rotation established, start thinking about those H's and T's, especially if there might be a place for thrombolytics, because if you push TPA, then you need about at least 15 more minutes of chest compressions. And then obvious but very hard to do, try to maintain the situational awareness, listen to what's going on in the room, and while you're also thinking about what could be going on. And it's okay to assign someone else, like, I'm thinking about H's and T's, you go find out where the airway team is, if they have a tube in. Make sure you get an X-ray order. What I would say is, if you're not the code team or the patient's primary team, that you don't need to be there, and it just adds confusion and stress to an already stressful situation. Any other thoughts, Sneha?
Oh, that's good on the codes.
Cool. And then finally, I think the one other relatively emergent situation that we sometimes find ourselves in is a stroke alert. These are usually a little bit less high stakes feeling, but certainly make sure as you're getting into the room to check the blood glucose. You can start performing the NIH stroke scale. Depending on which hospital you're at, it's us versus neurology who gets called first. If neurology isn't already there, make sure they've been called and out of the way. And this QR code takes you to a PDF of the NIH stroke scale. And then make sure the patient gets a CT head. The reason that we want to call a stroke alert sometimes, even if we're not sure, is by calling a stroke alert, the patient gets the CT head before anyone else uses a CT scanner. And so it really prioritizes the imaging for them. Don't feel bad about that. If you have clinical suspicion, it's worth it. Okay, cool. Sorry, that's anything else, Neha, there?
Nope, that's good.
Okay, now.
Perfect. Last,
communication.
Yeah. We just wanted to talk about our communication tools that we use in the hospital and how best to optimize these. So first, we wanted to talk about expectations. Today is the first day of the rotation, and so please set aside time to sit down as a team and discuss expectations. Most conflicts arise from poorly set and unmet expectations. And so, sitting down with the team, being like, okay, it's coming up to the latter half of the year. The intern's feeling more confident. They want to be given more autonomy. And so if you're an intern in that position, please voice that to your senior, and there will be less frustration when they're checking over all of your orders. And if you're a senior feeling like your intern is ready to take on more of the work, say, hey, during this time, I'm going to expect you to do 1 or 2 admissions, all of the discharges, and maybe try 1 discharge summary. And then if you feel comfortable with that, go ahead and say, yes, I would love to try that out. But as the days go on and it feels really overwhelming, come back to the expectations and say, hey, senior, it's really been overwhelming. I'm having a hard time prioritizing. Can we either walk through how you do this, or can you take away some of the responsibility I was given early on? And so having clear-cut expectations will reduce conflict and frustration in the team. So please take time today to sit down with the rest of your team today. And then similarly with feedback, it's really important to ask for and receive feedback and make it clear that it's being given. And so obviously stating like, hey, student, great presentation. My feedback on how to improve is blah. Hey, intern, it's halfway through the rotation. Can I give you feedback today? So that the receiver knows what's happening and are actively going to try and incorporate this feedback in their next presentation or in the next few days with you. And then asking for feedback can be difficult sometimes, but be straightforward and use the word feedback in asking for it. And then remembering that negative or constructive feedback is not about who you are, it doesn't reflect who you are as a person. There's no shame attached to it. Try to think of it as ways that you can improve and ways that you can be in the shoes of the physicians, nurses, all the people that you admire. And so try not to take it personally. I say this because this is something I do, and I take constructive feedback personally, and that's just how I am. And I have to remind myself it's not who I am, it's what I can do to improve. I wanted to see if anybody had any questions or comments thus far. I know we have some seniors up there. Anything you've noticed in giving feedback or receiving it? No? Okay, then we'll keep going. So next up are notes. So another way we communicate with each other, with ourselves, and with our consultants, and then upon discharge with providers that'll take care of the patient in the future. And so some tips and tricks to begin with are considering signing up for dictation if that's something that you find useful. I've had it and like using it sometimes. I'll be walking up from the ED and dictating the H&P as I'm walking around the hospital and using up that time. It's to each their own. Creating lots of templates and dot phrases, the next slide will show you some of mine, are going to be your best friends to really cut down on time writing the things you have to write 100 times. And then as we mentioned already, write as you go. And so pull up the chart when you're talking to the patient and jot down some notes. So as I said, dot phrases are really helpful. There are some short ones that I have, and then some really long ones that I have, like on the right side. We do a ton of DKA admissions, and so I just have an admission H&P for DKA and the things that you have to think about for every patient that comes in with this. And so I just hit F2 and fill in those 3 stars as I go on. On the bottom left, you can see I have one for cirrhosis. And so the way I think about cirrhosis is the same each time, and to make sure I'm not missing thinking about a key component. And so make these dot phrases and then use them each time you have a patient. Of course, they'll change, they'll flex, whatever, but it's nice to have a template so that you're not using precious mental energy that you can be using to clinically reason versus thinking about DVT and whether you've written that down or not. And some pitfalls that we've noticed and that you can avoid in the future are that if you are somebody that creates an update section at the top of your note, that's fine. Some people prefer that to keep up to date on what's going on with the patient. But then if that's the case, you must match the rest of the note, because if the update section says the patient was extubated whenever, but the bottom of the note says the patient is intubated, sedated on 3 paralytics, that doesn't match, and the next person reading your note doesn't know which is the actual truth unless they go and see the patient. And that's just incorrect. And so please make sure that your entire note matches itself. If you use copy forward, go ahead, Amelia.
They have in terms of updates and just in general, when you're referring to when something happens, please don't use today, tomorrow, or yesterday. Use the date. It's much more clear, because otherwise it says that the patient had their lap chole yesterday for 4 weeks. And it's very, very different if they're 1 day post-op versus 28 days post-op.
Thank you. You mentioned our bullet number 3 already, so great. Okay, so copy forward as a function exists for a reason, right? We do want to make some of our lives easier. And so if you took on day 2 of admission 30 minutes beautifully writing out all the rheumatology labs you ordered for this patient, copy forward helps, because then that forwards it to the days in the future. But then what you have to make sure is that the ANA doesn't remain pending for 7 days, right? When it comes back, you update that part of the note. And so if you are going to use copy forward, you must read the entire note every day and correct errors. And, we're mentioning this today is because we've heard from attendings and we've seen it ourselves that copy forward errors are happening, and we want to reduce these. Of course, it is preferable to not use that function and to write a new but brief note daily. Progress notes don't have to be long, and so you can keep them short, but write a new one every day. If you need help in what is important to write, look to your attending's addenda. If you look at any ICU attending's note on top of your note, they've written out exactly what they think is important that day, and try to mimic that the next day when you write your fresh progress note. Okay, and then finally, if you are going to use dictation, please read through that to make sure there are no dictation errors. The software does function well for the medical field, but sometimes it doesn't understand every word or acronym we say.
Awesome. And then I think Dr. Rains is here, and he wanted to share some thoughts about overnight, how to help and how to be your best resident at night.
Great, thanks, Amelia. I am probably not as proficient at Zoom as you guys. I just wanted to show a quick Word document. It's usually share screen, is that right?
Yes.
Yeah, you should be able to.
Let me see while I'm working on that. So like Amelia said, my name's Josh. I'm a nocturnist here at the university. A lot of you probably already know me. I did residency here and just graduated last month. You know, I know nights at the university can feel a little bit isolated. You can feel a little alone and not quite sure about, you know, who's your support person and who to reach out to. So I just wanted to briefly show you guys a couple of things. You guys able to see this Word document here?
Yep.
Yes.
Good.
Perfect. So just briefly, we have 4 main Nocturnus roles overnight. We have NOC 1 through 4. NOC 1 is really your go-to overnight for interns who need help with CrossCover, and NOC 1 is also our admitter and educator. So NOC 1 staffs all of the swing resident admissions. So it's usually the person that you're going to reach out to on swing whenever you're ready to staff. We don't technically staff the night resident admissions, but we're always available and always happy to help. So if you are a night resident or night intern doing an admission, you just want to pop by and run plans over, we're more than happy to hear from you guys. We sit on the 9th floor, second hallway by those center elevators. A couple other roles for the Nocturnus overnight. We do have a NOC 3, which is one of our advanced practitioners. They are a part of the drip. They also do some CrossCover. And then NOC 4 is our triagist. They do some CrossCover and then are actively speaking with the ED on behalf of the admitting teams, kind of doling out admissions and figuring out where they go. You know, like I said, I think sometimes the university is so big, it feels like we're not quite sure who people are. And I just want to put some faces to names here. So you'll probably see a couple of people you recognize. Kylie was an old chief. Tyler graduated a few years ago. There's this slob down here in the bottom. And then I don't know if you guys can see this, but this, if you haven't met Jason Persoff, this is the most Jason photo I've ever seen of him. Fantastic photo. But mostly this is to say, like, we're here for you guys. You know, we are kind of people behind the masks, and a lot of us chose to stay in academic medicine specifically to work with residents. I want to talk briefly about the board here. Honestly, like 4.5 years into UCH, and I still don't fully understand the board. I totally understand when people are coming in the morning looking at that with blank faces, but some really basic stuff. So in the sort of mid-right column here, you're going to see who has your CrossCover. This is more for ACE 1 and 2. It's almost always NOC 1. Obviously, medicine 1 through 4 is covered by the intern overnight. So look to see here who's covering ACE 1 and 2, and then you can come down to this box here, and it'll say who's your NOC 1. You know, obviously, you guys don't know everyone and their names. Just holler. We're happy to help point you in the right direction. In terms of figuring out what the heck these names are on the board, generally what happens is each admission overnight gets written under the appropriate team, and then we put it in the color of the nocturnist who you can grab sign out from. So you can see ACE 1 had this patient in red, so Jen's going to have your sign out. So you walk in, you talk to NOC 1, you get your CrossCover, You look at the board and you say, okay, I've got one admission and it's Jen, so I'll talk to her. Just a little bit of help with the swing and the night residents. When you guys are done with admissions, if you could print your H&P, write the name up on the board under the right color. So you see the night residents are in black, and then for the swing admissions, you're staffing with Jen, and so it'll go in red under the appropriate team. You obviously, once you hand them off to Jen, you can go home. If you can, when you guys leave, list on swing, knock 1 is first call. That would be fantastic. It would be so appreciative if you guys could list an end time. I know that sounds a little silly, but because we get all of our messages on our phone and through Haiku, if there's not an end time on that first call, we're often getting woken up sort of in our middle of the night, 10 a.m., 11 a.m., saying, are you the one taking care of this patient? Indeed, I am not the one who wrote the H&P at 3 a.m. and still taking care of them at 10 a.m, but no one believes me when I tell them that. Here is the clandestine drip sheet. This is not meant to be something that's secretive. I want to be open with you guys about the admission flow sheet, how we're doling these out. We're told kind of overnight by the powers that be to stick to this as much as possible, but nothing is set in stone. I think there is a benefit of kind of getting multiple admissions at once, becoming efficient at that, kind of feeling that stress, because I'll be honest, I still get 3 or 4 admissions in an hour and get stressed. I think it's how you handle that and how you get through that efficiently is a really good learning experience. On the flip side though, we want to make sure this is safe for you guys. If you feel like even just, 2 complex patients, or you've got to proceduralize someone and you just say, I need to tap out for a second, can you skip me? We are more than happy to do that. And our triagists are kind of actively looking at that time frame we're giving you patients. And often I skip you guys, even without even asking you guys, knowing that I probably need to give you a little chance to catch up. But again, that's all just to say, if you are feeling that stress and you do need to, skip an admission and go later in the drip, that's totally fine. Just message us and let us know. I think those conversations are always better received when you kind of approach it collegially and say, what you're feeling. I know when we're stressed, we get a little short. On the flip side, we have seen sometimes people say, I'm not doing this admission. I can't do this admission. And that puts us a little bit more in a defensive role. And, so just try and be collegial about it and have a conversation. And we're always willing to adapt things. Julia is still editing some of this stuff. So Sneha and Amelia, if it's okay with you, I'll send out this maybe later tonight. I know there's a lot of text here, but in brief, so our triaging is done by either a faculty APP, who most of our APPs have been here in triaging longer than we have, or a physician overnight. Overnight, we realize that we're super tight on admissions and you guys are super busy. We are actively triaging. We often call down to the ED to discuss team placement. We talk to other services on your guys' behalf. We call surgeons ourselves to try and get them there. We see if we can get them to the VA, Denver Health, Kaiser, and we do all of that in the background, especially overnight because we're so tight on spots. Ultimately, though, it's the ED who can say yes or no to an admission. Even as hospitalists, we're not allowed to say, no, we're not taking this admission. We're kind of like the fail stop, when no other service will take them. It's really our job to just take them. I think, just remember you are speaking with a faculty physician or APP. They're viewed as the same. Approach it collegially. I realize you guys get stressed overnight, and I do too, but sometimes we get a little bit of sass overnight when we're doling out admissions. And again, we're here to help you. I'm happy to adjust the drip, but try and approach that in a more, collegial fashion. And I think you'll get a lot more runway in terms of how we adjust the drip, rather than telling us things like, I'm not doing this admission, or I can't do this admission. And then just a couple of quick tips, we don't have an inpatient psych service. So unfortunately, we do admit for psych. Surgery often declines on things that aren't going to the OR that night. We're not big fans of that, but again, unfortunately, we can't change a ton of that. So that's just a brief note on triage. And then I just threw in some numbers here that are helpful for you guys overnight. So radiology reading room, a lot of times our chest x-rays, KUBs don't get read acutely overnight. you can just call them and have them read it to you over the phone. And then I listed inpatient pharmacy. I heard you guys talking about ultrasounds. I missed the part if you guys talked about where the hospitalist ultrasounds are, but it's the same place our workroom is, 9th floor near the central elevators. We have 2 or 3 general use ultrasounds. We're happy to, work on ultrasound skills with you guys. We're happy to scan people with you and happy to help out with procedures. So if you need any help with the ultrasound, just feel free to come grab one and grab one of the attendings. I know that was a ton of information for you guys, and it's your first day. I'm sure learning a new service is hard and busy, but mostly just wanted to sort of put some faces to names and give you guys kind of a general context of triage overnight, admissions overnight, and how the heck that stupid board works. I'll stop rambling. If you guys have any questions at all, I'll stay on. Also, feel free to shoot me a message. I'm on nights not infrequently, so I'll probably see some of you this month as well.
Awesome. Thanks so much, Josh. That's great.
Yeah, thanks a million.
And they really are really great overnight. I think anytime, even if you just feel like uncomfortable with like how you decided to package a patient, just be like, does this sound right to you? They're happy to listen to what you went through and offer thoughts, or be like, yeah, that's great. Awesome. Well, thanks for coming today, guys. We have in-person conference here every day. On Monday and Friday, Sneha and I are also doing the Zoom. The other days, it's just us in person. And then Wednesday is grand round. Let us know if you have any questions, concerns this month, and we'll see you around.